Welcome to Healthcare IT Today. I'm John Lynn, together with my colleague and friend Colin Hung. The world of technology and healthcare ever changing in new and novel ways, and that's why we love this stuff. So join us as we discuss the latest healthcare and health IT news, meshed together in new ways which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. Today, we're going to be answering 4 random health IT questions. And be sure to follow the show on social media at the hashtag HITSM and our personal accounts at TechGuy and at Colin_Hung. Plus, check out our 18 years of health IT blog content at healthcareittoday.com. I love random.
These random questions are fun, but sometimes they can be really hard, right?
We should actually. So here's the invite. If you're listening to this, send a random question to at Healthcare IT Today on Twitter or LinkedIn. Submit it, and then we can use those in the future. And maybe we won't even see them till we pull them up. So we get some user-generated ones next time.
That's right. That's right. And we promise we'll have one of our other colleagues look at them and compile which ones actually get in, so we don't know which ones are going to hit us.
Send it to Brittany Quemby if you know her. She'll aggregate them.
There you go. There you go. Well, let's get to the first random question, John. This will be fun. So the random question is, what aspects of AI worry you when it comes to healthcare and health IT?
So for me, the one that's top of mind actually came from a CIO podcast I just recorded. And we were discussing kind of the rollout of AI and what should a CIO be doing when it comes to AI. And I realized we're about to see Groundhog Day. If you remember when we rolled out IT in the healthcare organizations, hospitals, there was a lab system, there was a pharmacy system, there was a clinical notes system, there was a billing system, and it just like had this explosion of software because each department had their own, the radiology system, etc. And then eventually Epic built everything. Not everything, but they built all of those things that I just mentioned. And so then they're like, wait, why do we have a separate lab system and a clinical system? No, Beaker's good enough. It wasn't better than the lab systems, interestingly enough, but it was good enough, the pharmacy system, etc. Right. So I feel like this is my worry is we're going down that same path with AI, that we're going to have an AI for cardiology and an AI for, scheduling appointments, and we're going to have an AI for tracking the different other medical condition, one for every condition, one in every department with every, and we're going to see this like plethora of AI, and the IT people are like, wait, we have 100 vendors that we're working with on AI, not to mention our existing vendors that do AI as well, and that's going to be a problem.
Yeah, actually, that's a really good one, John. I hadn't even thought about that, but we may be heading for a day of departmentalized AI, which is probably not a good thing. But on the flip side, hopefully somebody does come up with the technology to actually consolidate all of that one day.
That's going to be the hard part, right? Like Epic could build this other application, but there's going to be so many innovations in AI. I don't think you can have one platform that does it. It's not, I mean, communication systems went through the same thing. You had your fax, you had your pager, you had your text, you had your secure text in the emergency room versus the secure text for the pharmacy versus they're like, wait, we have like 10 secure messaging systems or communication platforms. We need to consolidate them. Can we consolidate these AI? That's concerning because there's proprietary IT that's in, behind the AI. Can you just consolidate it? I'm not sure you can in some cases.
Hard to argue with that. I think for me, the biggest worry I have for AI, I think it will rear its head later, and that is the inherent bias that's baked into what the AI is trained on. So I'm not talking about AI for workflow or RCM or any of these kinds of things. That to me, that's fine, right? Like the sampling, there's not a lot of racial, ethnic, geography, social economic bias in that kind of data. And even if there is, we probably have a random enough sample, right? Like
There
when
might
you're
be
looking
some
at
benefit there, actually.
right. But when it comes to clinical decisions, right? And whether that's radiology images, whether that is potentially symptom checkers that are now starting to come out, we know already, it's been proven through research that there are underrepresented populations in medical research, right? That the women have not traditionally there's not enough women samples that have been done through research. So if these AIs are trained on the historical data that we've got available, which they are, then inherently there's these biases where there's underrepresentation, where it's mostly men, mostly of a certain age, mostly of a certain social economic status. That's what these things are trained on. Or even the bigger question, we don't even know what they were trained on, right? So that is my biggest worry about this, is that when we get into AI for clinical applications, that is going to rear its head. And that's my biggest worry, is that on one hand, it may set us back for a long time when these problems start to come up. And B, worse yet, if they do get implemented, that we were just perpetuating these biases. We've already seen those cases, right, with those AI bots around checking resumes, right? That it has the inherent bias to prefer men over women. Why? Because when it looks at the history, they go, well, there have been more successful men than successful women. Therefore, the resumes that sound more like men are going to be more the ones I prefer. I mean, AI is just doing what you said it was supposed to do. I fear the same problem can happen on the clinical side.
Hmm. I worry about that less for two reasons. One is that it's so front and center in every AI conversation. And so just the fact that we're having, I mean, even like we're doing right now, right? We're having these conversations, that's going to help improve it. And then the other part of it for me is that the baseline is already so low. Like there's already bias in the system that's what you're worried about being reflected in the AI, right? Like there's already bias in the system that I think now the system could actually solve some of those biases. And so are there still going to be biases? Yes, I agree with you there, right? Like and that is something we should be concerned about, and we should be thoughtful as we roll out AI. But I think that those biases are going to be less than the current system. So while it won't be perfect, it'll be an improvement over where we are today. And so to me, I still see that as progress, even if it's not the perfection that we wish we had.
Yeah, I think this is one of the few points we're going to disagree on, John, because I look at it and go, you look at how AI could or is already being deployed to look at claims data based on past other data, right? Like the past data. And it's going to make an assumption of, well, wait a minute, you shouldn't be having this claim because according to the, if you're earning 100,000 plus data that I've been looking at, you shouldn't be having this problem. So you must be faking it. I'm going to reject this claim, right? Like we know that this is going to be happening, and yet it's not reported. And so is there a human being afterwards that picks it up? Maybe, but the volume that this AI is going through, I mean, how many double checks is someone doing now, right? Like, so all I'm saying is you're right. I mean, is it any more biased than what we have now? No. I mean, people who are looking at it today, I would say equally are biased. But the pace at which AI can do this, the rate at AI can do this, it's a much bigger volume problem now than it was before. The bias happens much faster. Yeah.
So you're
So,
highlighting what the other aspect I worry about, and that is our over reliance on AI.
mm,
Like, you can't mention AI without mentioning the word Copilot these days, which is like almost overused. It's gonna be like the cloud, right? Like, what's the
right.
cloud? Like Copilot, what's that even mean? But I think what's going to happen is it's going to get so good that humans are going to stop looking, and
Mm,
and that becomes problematic because it's going to screw up sometimes. And what does that mean, right? And so right now in Copilot, they're going to see it and they're going to be like, yeah, we didn't talk about that, so of course that's easy. But eventually we're going to be so reliant on it because it's so good that then they're going to stop reviewing the notice in detail, because every other time, the last 1,000 times they reviewed it, they didn't have to change anything. So why am I reviewing it as much, right? So that is the other concern I have.
yeah. This sounds like we should have a whole episode on this, John. All right,
I'm
let's get to
sure
the
we
second.
will.
Let's get to the second random question here. The second random question is, what are the things in health IT that you feel are mid?
Oof, I mean, I really like this question because you were forced to say mid. Like my kids will be proud. But I would say the most mid thing for me in healthcare right now is analytics. Like it's so mid. Like it's talked about, it's incorporated into all sorts of solutions, but does it really make an impact? Is it really being used? Like, you know, probably just below mid is dashboards. Like Sure, they're useful when they're done right, and but I don't think they're being done right, and we don't have the right data. We're not using the analytics the way it should. In fact, I think that analytics is going to get leapfrogged by AI because humans can't analyze the analytics well enough, and the AI is going to do it quicker and basically leapfrog all those people doing analytics. So for me, analytics is really mid right now.
Okay. Okay. For me, a little bit surprising maybe. I think what's mid right now is patient communication technology.
Hmm.
And I mean like the lower layer. Like I don't mean like how to craft a better message. I think that's actually still exciting. But I'm talking about like we've been talking about email, text, and voice for like the decade. Like there's been no innovation in that side of things. I think we all, I'm not saying it's not necessary, it's totally necessary, it's totally needed. But to me, it's sort of like there's nothing happening in that space very much except at the layer of crafting messages in the language that people want it to be in, maybe getting a little bit more social engineering in the message content. But in terms of the actual, how you reach out, the methodologies, we haven't really branched beyond those three methods, right? Like nothing's really changed there. So in my mind, it's mid. It's just it's there. Right? Nothing really much is happening there.
I think you're right on the innovation front. Like, when was the last time we saw something really innovative there? And yeah, the closest I've seen is some of the AI responses to some of the communication. We're starting to see some smart routing of messages and a few things like that that maybe could enhance it in a interesting way. I know Modernizing Medicine was sharing some of what they're doing messaging wise, which they're not even a messaging vendor, right? Like they're the EHR vendor that's like, oh, we do need to engage patients and all that. So, I mean, it's interesting to see a few things there. Yeah, the other one I'd throw out that it actually pains me to kind of say that it's mid because it shouldn't be mid, but I feel like it is. And that's people actually caring about health equity and SDOH and topics like that. And maybe that's the wrong phrase. Like they do care about it, but they don't care about it enough to do something. And maybe it's because the business models aren't tied the right way. And I mean, there's all sorts of excuses and rationalizations for why we aren't going to do it. But it feels more like a conference talking point than an actual action. Like I bet if we were to look at 10 hospitals, health systems, large organizations, and we looked at their strategic priority that they share in their, announcement to the public, I bet we wouldn't see it anywhere. And that, I mean, I guess that's to me the definition of mid, and it's unfortunate.
If I could, I'll add one more than John too, since you threw it. I think one thing that's mid for me, uh, online only conferences. I mean,
I
you
wouldn't
know,
even put it that high, man.
that to me is like, you know, yeah, like, yeah, those those are not a thing for me. But I mean, they're still around. I still see some. But these virtual conferences, they just don't do it for me.
So, Colin, that brings up a controversial topic. I saw, I think it was Christina Farr talking about it recently. She's talked about it a few times. What do you think about the Zoom call versus the phone call? Like, I think Zoom calls are mid for a lot of people. Like, and so, like, there is some cognitive overhead of seeing the person, but Christina argues like, hey, I switch it all to phone calls and I go walking as I'm talking to them. I think it's interesting, right? Is the Zoom call mid and the phone calls are hot?
We have a whole one on that one too. For me, I actually like the Zoom call when it's one-on-one because there you get the benefit of facial expressions and things that you don't get when you're just on a phone call with one person. However, a conference call where you have like dozens of people on there, to me that you're better that and a phone call, a conference call are no different because you can't possibly process that many images and what are people doing and people flicking their cameras off and on as they go on and off camera. Like it's that doesn't feel very useful for Zoom. So I think I agree with Christina when it comes to like those larger ones where you're just participating. I think a phone call is just as good. But for one-on-one, I do like seeing the person because there's some things you can show and have and use your hands and things which you can't see when you're just on a phone call. So I actually do like that part of it.
Hmm. Yeah, and I like it when it's someone you know really well. Like I think that depends. If it's someone new and we're just doing a sales call or whatever, I don't really care kind of either way. I'd rather, in some ways, rather just do the audio, even if it's Zoom, but just audio. But I also don't want to walk. I don't need that either. I want to sit while I'm doing it. Maybe I'm lazy. I'm going to gain weight,
Oh,
and my tracker's telling me that's a bad idea. But
I think it's more, John, what you and I are saying is that we just don't do anything as interesting as walking or doing anything. So we're just sitting here anyway. So we might as well be on camera.
yeah, that's a good point. I've already set it all up. It doesn't. Yeah, I'm kind of ubiquitous. It doesn't matter. Like what I like to do, lead with whatever they want, and so that's what I approach it.
Hey, if you're just tuning in, you're listening to Healthcare IT Today with John Lynn and Colin Hung. Today, we are talking or tackling 4 random health IT questions, which were posed by our colleague, Brittany Quimby. So kudos to Brittany for giving us these random questions. This next one is a tough one, John. What health IT companies are killing it right now and why?
My initial response to this is like no one. like
No one.
and
Okay. All right.
the only exception might be ambient clinical voice, but I think even they're struggling because they need the HR vendors to integrate with them. And so like until they get the HR integration, they're struggling in their own way, and they're struggling because there's so much competition. So, even though the fact that everyone's looking at this and it's a hot market, they're competing with against a lot of people. So, we'll see. We'll see who does kill it within that. But it's a struggle for them too because there's so much competition within it. So, yeah, I mean, and I think the struggle for most of these organizations and the reason they're not killing it right now is because the provider organizations are suffering. They don't have the budgets to be able to do it. They don't have the opportunity to be able to invest the way they do. So anyway, that was my initial response. I will say that as I've thought about it a little more, I was thinking about a conversation I had with a IT digital health leader at a health system, and I talked about like Dell Technologies, and they're like, yeah, and we were talking about like quiet, companies in the industry that are making a big difference. And they're like, yeah, Dell's that kind of company, one that doesn't make a lot of noise but has a really big impact on it. And so, anyway, they're doing well, because people still need to buy servers, still need to buy storage, still need to buy desktops, all of those things. So I think there's all these infrastructure companies that are pretty quiet, and they're doing better than we probably realize.
Wow, that's right along the line where I was going to go. So I agree with you in the sense that we're in that lull, right? Like it's hard to say there's a company killing it right now because we are in this sort of downturn in the healthcare economy. Providers just aren't making as much money, they're not spending as much, and so we're all hurting, right, in health IT. But I think it's the infrastructure companies that are coming back first. And I think it's because that's the first thing they have to replace, right? That's the most obvious thing to go, hey, if I put this off long enough, I need to start replacing my Wi-Fi nodes. I need to upgrade that. I've got a new building now I have to put up or a clinic I've bought. Like those are things that happen all the time. So I think the infrastructure companies are probably doing well, relatively killing it. And I think to your point, the cloud-based platform operators, I think, are killing it. I think
Mm, good
the
one.
Microsoft Azures, the Amazon Web Services, as hospitals finally move more and more things to the cloud, I think those organizations are doing fairly well, right? I hear a lot about people moving, all these other systems, maybe not necessarily EHR because they're tied to the EHR vendor, but all these other ancillary systems, they're moving them all to the cloud or moving them all onto Microsoft's Azure platforms and things like that. So I think to your point, like storage, all those things, I think those organizations are doing pretty well.
Yeah, I mean, just look at someone like Cisco. When
Right.
did you last see them at a conference or hear them on stage? Not very often. Like at HIMSS, you might see them or something, but you don't see them very much. But they're in pretty much every healthcare organization. Like they're doing well. So I think the infrastructure ones are a really interesting one. How
Yeah,
about? Oh, go
go
ahead.
ahead. I was gonna say, so the other one I was gonna mention, John, I mean it's an easy choice. And I would have to say Epic is killing it right
That's what
now.
I was gonna say.
Right? Right? Like, let's be honest. with everything that's happening with all the other with that's happening in that market particularly, the one organization that's emerging as the winner, like them or not or hate them, I mean, people are turning to Epic and going,
Yeah.
well, maybe I should adopt more Epic, right? In most cases, it's more Epic, not just I'm moving to Epic. It's more I'll just have more Epic. So I think they've hit on a magic formula, especially as people look to reduce the number of vendors they deal with, simplify their infrastructure. I mean, there's a compelling reasons to go more into the Epic ecosystem.
Yeah, I will say, that was so funny that you were going to say that because I was say, do you think Epic's killing it? They've been killing it for a long time. So is it still considered killing it if you're still, if you're just doing what you've been doing for the past lot of years? I don't know. That's an interesting discussion. I do think though there is a bit of growing discontent with Epic and a bit of like of course when they've invested so much we're not going to see a turnover real quickly, but I'm hearing more people be a little more vocal about and it's interesting, is it really a problem with Epic or with the EHR in general and the burnout that they feel from the EHR and what the EHR represents? I'm not sure clearly if it's there, but because Epic owns that market in such a big way and is the leader in that market, they're taking the blunt of the pain that these people feel. And so that's where I think it's interesting that they are taking a bit of ragging as well from people who are like, I hate every second I have to spend in Epic, right? You're hearing those type of messages from doctors, from the users. Of course, are the doctors the one that choose it? No. So I mean, Epic's going to be fine, but yeah, it's funny we both thought of Epic.
Yeah, I mean, it's true though too. They've been doing well for so long. Is it really killing it if you're just continuing that trend? But I mean, I will say the one additional aspect to what you just mentioned, John. We certainly in Canada are seeing more and more Epic implementations, or at least I'm becoming more and more aware of Epic implementations up here, and they are switching from whatever they were on before. Now in the Canadian market, we've had a mishmash of EHRs, and there have been a lot more new, larger health systems formed because of the consolidation that's happening up here. So, but just hearing about more implementations of Epic up here, so to me, they are winning. Like they just seem to be winning a lot more deals. So I think they still are, maybe just in new markets, right? Whereas in the US, I think it's pretty stable these days. But
Well, even then,
internationally,
UPMC went there, Intermountain's going there, right? Like, and then of course, all of their customers are acquiring, so they're growing just from the acquisition of their customers acquiring other healthcare organizations. I do think it's going to be interesting to see how Epic plays out internationally. Can they adapt their model to the international model of care? I'm really interested. I kind of wish that they would have won either the DoD or the VA. So we could have seen how they did versus Cerner, or I guess Oracle Health or whatever you call it these days. Like I would have liked to see would Epic, because I could have imagined a scenario where Epic wins that contract and then says, nah, we're out because we can't adapt to everything that you need. Because the DoD and VA have very specific needs and they've had very custom software built for them. And so I wish they would have. I don't think we're going to, and I don't think we're going to have it switch, but it would have been interesting. And so the same internationally, are they going to be able to adapt to the international needs? I'm interested to see how that plays out.
well, John, we've just got just enough time for our final question, and that is, what has been your favorite cities to attend a conference at, and why?
So I mean, my bias is live music and probably food. I think that's probably where I go with my bias. So that's why Nashville and New Orleans are top of the list. I think for me, when it comes especially to the live music, I just love being able to go and hang out and hear it, after hours with colleagues, etc. Boston is up there because of the whole Italian Little Italy section for me, and of course cannoli. I love that. Plus, I think it's just a cool town to walk around and everything. Not as fun to get to as some of the other places, but and then the other one I'll throw out there, and I actually haven't been to too many events there, and there's a good reason why. But I love New York City. Conferences in New York City are a lot of fun, although they don't happen nearly enough.
Wow, those are great cities. I think the only one we have in common is Nashville. So
Okay.
I love Nashville. Like you, the food is amazing. The ambiance there is awesome. I love that downtown, of course, Broadway and everything, but also the food hall they put up there. It's
Yeah,
a great
that's
place
cool.
to have a conference. It yeah. So I like that, and I love actually the convention center is pretty cool. Like the way they've
Yeah,
done it,
not
it's
bad.
very nice. It's a very good venue. I can't say Boston just because I'm from Toronto, and that would be wrong of me to say Boston. So, but I acknowledge it is a pretty good city. The seaport area. I love seafood as well. So, hey, the chowder there is awesome. So, um, but for me, I actually like San Diego. I mean, it's one of my favorite cities to go to in general. It's a walkable city. The harbor there is amazing. So much to do. Every time I go there, I discover something new to do there. So, and I love events that are held there. But like New York, not enough of them are held there. So,
Yeah. It's a hard
uh,
one for me because do I drive or do I fly? And then it's like, I don't know. But I love it. It has a lot of good characteristics for sure.
and then this is going to be controversial because I love it, but I know people don't like it from the infrastructure. I actually like Chicago as a destination for events. Right. For me, it's easy to get to. The public transport is really good. There's that you just ride the subway straight downtown. It's, not that bad. Lots of hotels to choose from. The food scene's pretty good. The only thing is the convention center is a bit out of the way, right? And so it's not the easiest to get to, but I love the city. I mean, I love deep dish pizza. The architecture there is amazing. Yeah, I love Chicago. So
Yeah, at least you didn't say Orlando. Chicago is mid for me. It's fun. You're right. There's a lot of good aspects, but there's some really bad aspects. So I think they drag it down.
well, I mean, Orlando is on the top of my list, but not because of the conference, just because of, Disney that's there. But has
I've been
nothing.
like a dozen times and never been, so I don't know what that maybe that's
Uh,
why I hate Orlando.
well, I say, and for us Canadians, Orlando's pretty good in the winter, right? Like, hey, I'll take an Orlando
The
event
weather is
in
nice.
March.
Yeah, Point in Orlando's nice too. I'm down with that, and there's some nice places to stay. But yeah,
Well, that takes us to the end of the episode, John. So thanks to all of you who tuned in to this episode of Healthcare IT Today. You can find out more details about our show by checking out the programs page on healthcarenowradio.com. And please share your voice and engage with the community at healthcareittoday.com and on social media using the hashtag HITSM. I'm Colin Hung with my friend and Health IT collaborator, John Lynn. Thanks for listening and have a great week.